everyone. So today we'll be starting with the topic renal tumors. Alright. So let's begin with the classification of your renal tumors. There are your benign renal tumors and then there are your malignant renal tumors. Alright. So under the benign renal tumors, we have your renal papillary adenoma and we have your angiomyolipoma and your oncocytoma. Alright, so the benign renal tumors are usually small, and incidental findings. Alright, and under your malignant renal tumors, we have your renal cell carcinoma. Alright, so let's start with your benign renal tumors. Alright, the first benign renal tumor we'll be starting is your renal papillary adenoma, which is also known as cortical adenoma. Alright, now this is usually asymptomatic, but is associated with two conditions, that is your chronic pyelonephritis and benign nephrosclerosis. Alright, again, this is an incidental finding. Now let's come to its gross. We know the tumor is relatively small. It is about 1.5 centimeter in size. It is circumscribed, or solid lesions, and the cut surface of tumor is usually white to yellowish. Alright, now let's jump to its microscopy of your renal papillary adenoma. We see your papillary lesions. Alright, we also see your psammoma bodies. There is no cellular atypia. Alright, so the last point is that if the size of your RPA, that is your renal papillary adenoma, increases by 3 centimeter, it can progress to your renal cell carcinoma. Alright, so this is one of the complications of your renal papillary adenoma. Now let's come to the second benign tumor, that is your angiomyolipoma. Alright, again, this is a benign renal tumor. So let's start with its origin. So this tumor originates from your perivascular epithelial cells. Alright, and it is associated with your tuberous sclerosis, that is TSC1 and TSC2. Alright, coming to the microscopy of your angiomyolipoma, we see that there are abundant blood vessels. Alright, we also see smooth muscles and areas of fat. Alright, the complication or risk for your angiomyolipoma is spontaneous hemorrhage. Alright, with that, we'll be finishing it with your benign tumors, and we'll be jumping to your malignant renal tumors, alright, which is your renal cell carcinoma. Alright, so let's start with the introduction. So under the introduction, we'll be reading about the incidence. So your RCC is more common in the age group of your 50 to 60 years. Alright, so that we'll start with the etiology. So under etiology, we'll be starting under 3 headings. One is your sporadic causes, your syndromic causes, and certain other factors. Alright, so let's start with your sporadic causes. First being your tobacco. Yes. Second are your petroleum products. third is obesity, and lastly, increase in estrogen. All right, so these are the sporadic causes for your renal cell carcinoma. All right, now let's come to the syndromic causes. These are your familial conditions. So under this, we'll be starting 3 conditions. All right, the first being your von Hippel-Lindau disease. The second is your hereditary papillary carcinoma, and third is your Birt-Hogg-Doob syndrome. All right, so let's first start with your von Hippel-Lindau syndrome. All right, so this is an autosomal dominant inheritance, and this condition increases the risk of clear cell RCC. All right, the second condition we saw was your hereditary papillary carcinoma. All right, this condition too is an autosomal dominant inheritance, and it increases the risk of your papillary renal cell carcinoma. All right, now this hereditary papillary carcinoma is a MET proto-oncogene. All right, so the third etiological factor under your syndromic causes was your Birt-Hogg-Doob syndrome. All right, now this too is an autosomal dominant inheritance. Yes, and this condition increases the risk of, firstly, your chromophobe renal cell carcinoma. All right, also your pulmonary cyst. All right, so now let's come to the other etiological factors which can give rise to your RCC. All right, the first is your cystic diseases of kidney. Yes, the second is exposure to heavy metals or abscessos. All right, and thirdly, analgesic nephropathy. Yes, so now that we're done with the etiology, let's jump to the subtypes of your RCC. All right, so to study the subtypes, the 3 most important subtypes, we'll be studying in a table format. All right, so let's start with your clear cell RCC. All right, now this is your most common malignant renal tumor. All right, now let's look at its origin. Yeah, this originates from your PCT. All right, now coming to its gross features. If this is your kidney, all right, the tumor this is your tumor, and we see right. So what do we see here? We see the tumor. All right, we see the tumor is located on the upper pole. All right, so the first point under gross is that the tumor is located in the upper pole. We see that there's a yellow area, yeah, along with hemorrhages. All right, so these are your 3 gross features of your clear cell renal cell carcinoma. Firstly, the tumor is located on your upper pole. We see a yellow area and areas of hemorrhage. All right, now under microscopy, we see clear cells. All right, so coming to the microscopy, the histological features, we see your clear cells here. All right, yeah, so We see your clear cells. We also see a glandular pattern here. Yes, we also see solid patterns. We also see your granular cells. We see that the tumor cells are uniform, all right? And we see residual compressed renal parenchyma. So yeah, we can see that the renal parenchymas here are compressed. All right, so these were the histological features for your clear cell renal cell carcinoma. Now let's come to your papillary RCC. All right, so the origin for this is your PCT again. Yeah, so the tumor cell are arranged in a papillary pattern. All right, now coming to its cross, we see multiple lesions. Yes, and in its microscopy, we see a papillary pattern along with samoma bodies. Alright, now the last one is your chromophobic RCC. Alright, so where does this originate from? This originates from your collecting duct. Alright, so the clear cell RCC, papillary RCC, both were originating from your PCT, whereas your chromophobic RCC originates from your collecting duct. Yeah. Now let's come to its gross features. So the tumor is usually brown in color. It is circumscribed, yes, and we see areas of central scar. All right. Coming to its microscopic features, we see perinuclear halo along with acidophilic granules. Alright, so that was it about your three most important subtypes of your RCC. Alright, few other subtypes of your RCC are collecting duct RCC. Alright, as the name suggests, this originates from your collecting duct. Alright, and it is located in your medulla. Yeah, and then there's your granular cell type RCC. Alright, and lastly is your sarcomatoid type RCC. Alright, this is anaplastic and poorly differentiated. Alright, so with that, we are done with the subtypes of your malignant renal tumors. A few extra points I missed out here. Your clear cell renal cell carcinoma occurs due to your von Hippel-Lindau disease. Your papillary renal cell carcinoma occurs due to your hereditary papillary carcinoma, and your chromophobic RCC occurs due to your birth hog tube syndrome. Alright, so we are done with the subtypes of RCC. Now let's come to the complications of your RCC. Alright, so your RCC can lead to ectopic hormone productions. Yes, so this leads to your PNS, that is your paraneoplastic syndrome. Alright, such as polycythemia. Second is your hypercalcemia. Third is your hypertension. Fourth is your Cushing's syndrome. And lastly, it could lead to feminization or masculinization. Alright, so those were the complications of your RCC. Now let's come to the prognosis. All right. So it depends on the extent of your tumor. All right. And there is 7% 5-year survival rate. All right. So the last topic in your RCC that we'll be discussing is the presentation. Yeah, that is your clinical features. How does a patient present to you? All right. So there are three presentations here. First being your abdominal mass. All right. Second is your abdominal pain or flank pain. All right. And lastly, hematuria. All right. So if there was a question to be asked, a clinical case scenario, the question would be like a patient presents to you. All right. A patient presents with a history of these three features. All right. It could be flank pain, hematuria, and abdominal mass. So this should suggest you that okay, the answer should be renal cell carcinoma. Right. So this can be asked as a 10 marker. So I hope you guys enjoyed the video and thank you for watching.